Hello and welcome once again to AnesthesiaTOOLS. With this session, we are starting a new segment called the Viva Table. And the first topic chosen is face mask, anesthesia face mask.
Face mask is something very routine in our anesthesia practice because we can connect the breathing circuit using face mask to the patient's face and directly administer the gases without any special airway gadgets. Okay, so the mask holding is the most important skill that anybody working in anesthesia should be familiar with. So, understanding the face mask as an equipment is also very important. This can be manufactured with plastic, PVC, neoprene, rubber, or a combination of these. Basically, this is a roughly triangular shape. This has three parts. This is the body or dome, this is the seal, and this is the connector or mount. Body usually is transparent nowadays, and previously we have our anatomical face mask which is made of rubber. So the disadvantage with this kind of face mask is patient who is claustrophobic might feel it uncomfortable, or when you are ventilating using mask you won't be able to see the secretions or vomiters or the breathing exhale gas condensation through this non-transparent things. So through transparent face mask we can visualize these, and this will be more comfortable to patients who are claustrophobic. This is the rim part of it. This can either be in the form of a flap or a cushion which can be inflated with air using a port like this. So it will give a better mask fit between the breathing circuit and the face. And you cannot have one face mask fitting for all. Different patients will have different sizes and shape of their face, so we need different sizes, as you can see here, right from pediatric size to the adult size. Pediatrics we can even have mask with this shape so that the dead space can be minimal, and we can also have the triangular like smaller mask called a Rendell Baker Sosek RBS mask, which will reduce the dead space further. So this is the connector through which you can connect the breathing circuit. This has got a 22 millimeter female connector. Our breathing circuit exactly fits into it, which can have a swivel connection. You can even connect an ambu bag or a resuscitator, manual resuscitator with this face mask.
To add a few more points which could be asked during your Viva session, we'll go through that also. You may be asked, when do you use face mask? We use it during pre-oxygenation prior to the induction of anesthesia. Inhalational induction of anesthesia is done with face mask. Back mask ventilation, BMV, prior to intubation. Small cases, we could use it for even maintenance of anesthesia. BMV is used during resuscitation, and NAV ventilation, non-invasive ventilation during respiratory failure. Simple question, how do you hold the face mask? The aim in using an anesthetic face mask is to ensure a complete seal between the mask and the patient's face while exerting the minimum pressure that may cause soft tissue damage. So choose the correct size for your patient. When the patient is unconscious, the airway must be held open while maintaining the seal. Use your non-dominant hand to position the face mask. Ventilate the patient with your dominant hand by squeezing the bag or using the bellows. Easy clamp technique is usually utilized, where you use the thumb and index finger of the dominant hand or non-dominant hand to make a C, pressing the edges of the mask to the face, and use the remaining 3 fingers to lift the angles of the jaw, and 3 fingers form an E and keep the airway open. Remember to continually assess the adequacy of this technique by observing bilateral chest movements, listening for the air leaks, and assessing for the signs of inadequate face mask ventilation. These are the signs of inadequate face mask ventilation: absent or inadequate chest movement, absent or inadequate breath sounds, auscultatory signs of severe airway obstruction, cyanosis, gastric air entry or dilatation, decreasing or inadequate oxygen saturation, absent or inadequate exhaled CO2, absent or inadequate spirometric measures of exhaled gas flow on your monitor, hemodynamic changes. Last few are very late changes of inadequate ventilation. How do you define difficult face mask ventilation? ASA has defined it as a situation in which it is not possible for the anesthesiologist to provide adequate ventilation because of one or more of the following problems: inadequate mask seal, excessive gas leak, or excessive resistance to the ingress or egress of gas. Various stages of difficult mask ventilation has been graded by different authors. Shown here is the classification proposed by Han, and it is very important to document the events during face mask ventilation while writing your anesthetic chart, because that is going to help during your extubation and future anesthetic exposures. There are certain patient specific factors causing difficult mask ventilation. It is enumerated here, and these are some of the common mnemonics to anticipate patient specific difficult face mask ventilation. MMM mask, that is male gender, mask seal which is affected by beard or being edentulous, myelopathy grade 3 or 4, mandibular protrusion, age above 55, history of snoring or obstructive sleep apnea, and obesity or kilograms. Again, obese is another mnemonic to catch these patient specific factors which is mentioned here. These are the methods by which you troubleshoot depending on the cause of difficult face mask ventilation. The list is given here. So if you want, you can pause the video and check all the interventions possible in different scenarios. Here I have given the flowchart for unexpected difficult mask ventilation. You can go through the algorithm and you can identify the critical steps to be taken in case of a difficult face mask ventilation, when to switch over to supraglottic airways, when to consider or attempt intubation, and when to go for invasive emergency airway or front of neck access. Difficult mask ventilation, you need to adjust your technique. This is how you hold the face mask with two-handed technique. It is mentioned as double CE grip. Again, it's a similar approach to EC clamp to one-hand technique described before, with the additional hand adopting an identical position on the other side of the mask and face. Alternatively, the mask can be supported with the thumbs while index and middle fingers hook behind the angle of jaw to keep the airway open. What to do when a patient is having dentures? If the dentures are secure, it is often helpful to leave these in place for face mask ventilation, as this helps to support the mouth and prevent the cheeks becoming sunken as shown in the picture. However, loose dentures should be removed as they can potentially dislodge and occlude the airway. Now we will go into certain special types of face mask which could appear on your Viva table. Everseal face mask with a soft pliable flap. Anatomical face mask, the classical conal type black rubber with air filled cushion. The third one is face mask with flap. This one is transparent. Again, you can have a transparent face mask with adjustable air filled cushion and transparent face mask with pre-filled air cushion. Another type will be ambu face mask, which is used with the manual or automatic resuscitators, ventilators and anesthesia circuits. It's available in adult as well as pediatric sizes. Latex free face mask is very important and it's available nowadays also. So this is without the associated danger of type 1 or protein allergies. RBS face mask, Rendell, Baker and Sosek mask. This is for the neonates and pediatric sizes to reduce the apparatus dead space. It's available in black rubber and clear material as well. Or you can use circular silicone face mask for small babies. Scented face masks are very popular for your inhalation induction, especially in pediatric patients. Different flavors are available in the market. And nowadays, endoscopic procedures being very common inside the operating room as well as non-operating room locations. So, Patel Syracuse face mask is shown in the picture. This has got a silicone seal over the endoscopy port. So while mask ventilation or tight mask seal is maintained, the endoscopy can be introduced through nasal or oral way. And the modern endoscopic masks have a slightly different anatomy. They have a port or diaphragm in the mask body which allows fiberscope to be inserted into the nose or mouth, and the difference from the former is the membrane port is located right in the center, and it allows for the tube connector of armored ET tube to be pulled out through the membrane after successful intubation. Remember, many times we use armored endotracheal tube railroaded on your fiberscope for difficult airways, and the connector, ET tube connector, is usually not detachable. So in such cases, these endoscopic masks are helpful. Other rare things for dental chair anesthesia, you can find Mackensen Comfort Cushion Nasal Inhaler. It's not called a mask because masks for some dental anesthetic techniques are designed to fit in the nose only, so that the dentist can have unimpeded access to the mouth. Again, in the face mask itself, you can have a different set of face masks for a non-invasive ventilation, and it could be vented or non-vented type. It's a topic in itself. We'll take it in a different session on table Viva. How do you clean or sterilize? After each use, the contaminated reusable face mask should be soaked in water with detergent, cleaned thoroughly, and rinsed, dried, and then subjected to sterilization or high-level disinfection, taking care not to damage the pneumatic cushion. Whereas some face masks withstand high temperatures of autoclaving, others do not. Since these are not easily distinguished, many adopt uniform policies for disinfection. Care must be taken if chemical disinfection is used, as some chemicals like chlorosilinol are known to have been absorbed by the material of the face mask and have resulted in injury to the patient's skin. Disposable single-use face masks have become more popular. It avoids the cost of sterilization. The materials and components are cheaper, and there is much more limited range of designs and sizes. The use of inert plastics eliminate the risk of allergy to latex. Most of them are transparent, and we have the potential to add scent to the plastic, making the products more readily accepted by patients, especially children. There could be more topics in the Viva table, like complications of face mask ventilation, nerve injuries proper, apparatus dead space, definition of anatomical dead space, self-retaining straps for face mask. It is shown in the picture here. It's also called mask harness, and comparison of face mask with supraglottic airways, the mask over tracheostomy, etc., etc. Just to mention about nerve injuries possible, it is mentioned in the literature that during any mask ventilation, avoid compressing on the eyes and excessive pressure on the face. Prolonged period of mask ventilation with anterior displacement of the jaw may occasionally produce the injury to the lingual and chorda tympani nerves. This can lead to loss of taste and tongue numbness. Acute transient CL adenopathy has also been reported secondary to compression of the salivary duct. So that's it for the time being. Viva Table station on face mask. If you are a teacher or a student, you know more questions or more topics connected to this Viva station, do let me know by texting it on the comments box. You can also email me to my email shown on the screen, and all these lectures and videos will be available on my website also, onlineanesthesiatools.com. Until we meet next time with a different topic, it's me, Dr. Sanesh, signing off. Bye.